Bonjour à tous, merci de votre présence. Je commence déjà pour faire advenir le moment clé du démarrage de cette session. Je suis très heureux d'être là parmi vous et je voudrais remercier Jean-Pierre Deloued qui descend 4 à 4 l'escalier et lui dire que cette session 2017 est magnifique et nous le félicitons comme nous félicitons toute son équipe en le remerciant encore chaleureusement. Donc, je vais présider cette session qui est modérée par Marc AURIACOMBE, qui devait être remplacé, mais qui remplace le remplaçant. Et Marc AURIACOMBE, je vais lui demander de bien vouloir parler français, s'il veut bien, pour tenter de maintenir un peu une certaine présence de la langue française dans les congrès scientifiques internationaux. Mais vous savez qu'il enseigne à Philadelphie et qu'il pourrait très bien également enseigner à Barcelone. Donc, nous allons maintenant assister à 3 exposés d'une importance majeure. Je voudrais souligner l'intérêt particulier de ces trois exposés. Méthodes pour améliorer l'adhésion au traitement des troubles liés à l'usage de substances. Nous sommes tous preneurs. Comment améliorer l'adhésion au traitement d'ailleurs, il n'y a pas que nous, enfin je veux dire, il n'y a pas que des addictologues. Tous les médecins sont intéressés par des méthodes permettant d'améliorer l'adhésion au traitement. Je pense à tous ceux qui traitent les hypertensions artérielles, les diabètes, les épilepsies, etc. Enfin bon, on a vraiment besoin de ces méthodes-là. Rôle des interventions comportementales dans le traitement par buprénorphine des troubles liés à l'usage d'opiacés. Bien sûr qu'à une certaine époque, il y a déjà longtemps, j'espère, il y avait des files de patients, les uns comme ça, les uns derrière les autres, qui venaient prendre leur méthadone. Je ne dis pas dans quel pays c'est, dans quel pays au pluriel, mais qui venaient donc prendre leur dose de méthadone, qui avaient leur flacon d'urine. Alors bien entendu, l'infirmière vérifiait la température de ce flacon d'urine pour s'assurer qu'elles avaient été émises tout récemment. Et ils donnaient donc leur flacon d'urine et prenaient leur dose de méthadone, point. C'était ça, le traitement par substitution des patients à l'héroïne. Aujourd'hui, nous savons donc que ça n'est pas suffisant, qu'il faut des interventions psychologiques, psychothérapeutiques, comportementales, et nous avons besoin d'en entendre davantage de Roger Weiss de Boston. Enfin, intervention en parentalité auprès de parents présentant un trouble lié à l'usage de substances, une étude pilote. Et bien entendu, là aussi, ce sont des parents toxicomanes, ce sont des parents qui doivent tenter d'interrompre la transmission de l'addiction, puisque vous savez que cette chaîne transgénérationnelle est largement présente dans certains milieux, notamment défavorisés. Donc, voilà 3 exposés qui seront modérés par le brillant Marc AURIACOMBE, à qui je laisse la parole.
Merci Aimé. Pour ne pas perdre de temps, je reste assis. Merci pour cette introduction. Merci aussi pour tes gentilles paroles. Et j'en profite pour dire que pour moi, c'est un honneur d'être sous la présidence d'Aimé NICOLAS, puisque Aimé NICOLAS, pour les plus jeunes d'entre vous, fait partie des personnes qui sont parmi ceux qui font que la dictologie peut exister aujourd'hui en France et relativement, en toute simplicité, un modèle un peu pour le reste de l'Europe et le reste du monde. Donc ces paroles sont bien... J'allais dire ces paroles sont well taken, mais il m'arrive encore de parler français. Même s'il y aura des sessions où il y aura de la traduction. Et, bon. Sans plus attendre, donc, on va passer à la première présentation avec Ivan Montoya, qui travaille au NIDA, cette prestigieuse agence de recherche sur les addictions aux États-Unis, et où il est directeur de la division des médicaments.
Good morning. I'm going to speak in English. I don't speak French, unfortunately. I wish I could do my presentation in French. So I work in the Division of Therapeutics and Medical Consequences of the National Institute on Drug Abuse, NIDA, in Bethesda. I don't have any conflicts of interest in my presentation. During my presentation, I will mention some generic names of medications that will be used and some FDA unapproved medications that also will be mentioned. I also will present some data that has not been published, so I make sure that we don't jeopardize the publication of that data. So first of all, I want to thank Jean-Pierre and AURIACOMBE and Cecile and Marc and all the organizers for inviting me to present here. It's a great honor for me to be here today presenting this information. Before I start, I want to say that treatment adherence is only a part of this huge program that NIDA is developing right now, trying to improve and tackle the issue of the opioid crisis in the United States. I was telling Jean-Pierre after the previous session that there were fantastic questions that I think those types of questions will be tackled in the program that is being developed, not just by NIDA, by also the National Institute of Health, which is the umbrella, that's the biggest umbrella organization under which NIDA is part, so it's the National Institute of Health. So I don't have time to present right now all the details about that initiative, the opioid initiative at NIH. If there's time, maybe during the conference, I'll be happy to talk more about that initiative. I have some presentation already prepared for a conference that I'm going next week. I'll be happy to provide more details. So this issue of treatment adherence is just part of this general program that we're trying to improve the treatments in order to tackle the problem of the opioid crisis in the United States. So this is the outline of my presentation. I'm going to give a definition of treatment adherence. I'm going to talk about some of the determinants of treatment adherence, and then some methods to improve treatment adherence, including non-pharmacological, pharmacological, and some devices, and at the end, some conclusions. So what is treatment adherence? Treatment adherence is the extent to which patients follow the treatments as prescribed by their health providers. It's pretty straightforward, and adherence is preferred, the term adherence is preferred because compliance suggests that the patients are passive and is not in a therapeutic alliance. So during my presentation, I will be mentioning just the word adherence and not so much compliance. So in terms of measures, the adherence is measured by the percent of prescribed treatment taken by the patient over a specific period. And the issue of treatment adherence or lack of treatment adherence is spread all over medicine, and it was mentioned before, in many areas in medicine we have the same problem. And I think we all know that, for example, for obesity, the adherence to diets is extremely low. So the same thing is with substance use disorders. The adherence to treatment is very low. This is data from Ned Nunes and Mark Olson that was recently published, showing the percent of people that stay in treatment and are successful in treatment. And I just want to focus on this part of the graphic here. This is the number of people that in the United States are initiating medication-assisted treatment. It's about 250,000 people, and the ones that are retaining treatment for 6 or more months is less than half. So we have a huge dropout, and we have a huge problem with lack of treatment adherence, which translates in many complications, as we know. So in the lack of treatment adherence in substance use patients is expected because of some of the manifestations of the substance use disorder, which include a disorganized lifestyle and many problems with following instructions. The usual frequent visits associated with the treatment of substance use disorders, and some of the medications that we know can be diverted or misused, and some medications have a limited efficacy, and some of them have also side effects. And a big problem is that often the healthcare providers are reluctant to prescribe medications due to the risks associated with those medications. So low treatment adherence is associated with treatment failure, substantial worsening of the disease, and we know that in substance use disorder, that people who don't stay in treatment, they relapse and their disease gets worse, increase in healthcare costs, and increase in mortality. And part of this problem is what we are seeing in the United States with the opioid overdoses, and the number of people, about 60,000 people a year, are dying from overdose in the United States. The cost of lack of treatment adherence has been estimated in $100 billion a year in the United States. So it's not only the costs in health and quality of life, burden of disease, mortality, but also the costs in terms of dollars is extremely high. So it's a high priority right now for NIDA, for NIH, to find ways to improve treatment adherence. Some of the determinants of lack of treatment adherence include socioeconomic problems, lack of basic needs, lack of health insurance, lack of prescription coverage, the access to treatment, lack of education, some cultural beliefs. Some people believe that they don't need to stick with treatment, cognitive factors like memory, for example, or psychological factors like depression and anxiety, some perceptions by the patient of the risk-benefit of the intervention. Sometimes the patient feels that it's not helping and they drop out very quickly. The patient-doctor relationship, we all know that in medicine and in general in health it's important to have good empathy and good patient-doctor relationship. The confidentiality issues, especially associated with substance abuse treatment, and the severity of the disorder. But two things that I want to highlight in my presentation are the previous experience with treatment and the complexity of the treatment, specifically the complexity of the treatment. Why? This is data showing that the more complex the treatment, the more likely people tend to drop out. So this is the number of the adherence to treatment based on the number of doses that are prescribed. If you see once a daily, the adherence is relatively good, but once you increase to 4 times a day, the adherence is pretty low. So some of the strategies that NIDA is developing and trying to promote the adherence to treatment, one, as I mentioned, is non-pharmacological. Pharmacological, we have biomarkers, medication levels, for new formulations and new medications, and some devices. And I'm going to talk about each one of them. So for non-pharmacological, we know that it makes a lot of sense to have good access to treatment, have a flexible schedule programs that are adapted to the lifestyle of the patients and their needs and their schedule, their working schedule or their home schedule. They clearly explain the treatment plan, education about the disease and realistic treatment expectations, establish an empathic patient-provider relationship, engage the family, the friends, and the community in the treatment, and recognize by the patient and the family and those who are surrounding the patient the importance of the treatment adherence and staying in treatment. And one of the areas that we have explored at NIDA is the incentives for adherence, and I'm going to expand a little bit more about that. So this is data from a study that was published in 2012 demonstrating that incentives improve treatment adherence. So as you know, diphenylnaltrexone, Vivitrol is the commercial name in the United States, is an opioid antagonist, and the adherence to opioid antagonist is pretty bad in general because it doesn't have reinforcing effects. But when you provide diphenylnaltrexone with contingency management procedures, and when I say contingency management is incentivizing the patient so that when the patient is doing well, you incentivize with vouchers that can be redeemed in goods and services, so the patient will have an incentive to stay in treatment. The adherence to the treatment in 24 weeks is pretty good, as you can see in this figure. The Vivitrol is administered once a month. You can see you can have at least 74% of adherence in the treatment with contingency management versus just doing the prescription. So the importance of the psychosocial, and in this case, the contingency management with positive reinforcement is extremely important. Now, some of the biomarkers that are being developed is with the intention to assess the patient's adherence to the treatment. And the idea of the biomarkers is to see if, like adding this biomarker or this compound, a compound to the medication, we can test and see if the patient is really taking the medication. So those are some of the desired characteristics of an adherence biomarker. One is that it has a well-behaved pharmacokinetics, so it can be administered once or twice daily with very low blood variability, blood concentrations, and that it doesn't have drug-drug interactions, because if you want to have a biomarker that stays in blood and is clear, can be clearly evaluated in blood samples or in urine samples or in other fluids, that it has urinary excretion, because that's the easiest way to assess a compound rather than having to draw blood. So saliva is also acceptable, but we prefer urine samples because it is much easier. That it is not found in common dietary sources or supplements or pharmaceuticals. And in this case, I'm making a plug, and as you know, you probably know that riboflavin has been one of the markers that has been used to assess adherence to medications. Is a dietary source. Therefore, it can have a lot of false positives, and so it is not a very good biomarker. The idea is that it's something that is approved by the FDA with low toxicity, and that it has a viability that should substantially, it will not be affected by food. So what are the candidates that we have right now? We have two candidates that we are developing at NIDA. One is acetazolamide. Many of you are familiar with acetazolamide. It's a diuretic that is used for altitude sickness. The commercial name is Diamox in some countries. It's a carbonic anhydrase inhibitor. It has a half-life of 4 to 8 days, 8 hours, according for the label, and it has 100% viability, which makes it very desirable, and it has a therapeutic dose of 125 to 1 gram a day. That's the dose that is being used as a diuretic or for altitude sickness. We are testing a dose of 15 milligrams a day, so it's almost a homeopathic dose, as you can see. The other biomarker that is being developed is quinine. Quinine is an antimalarial medication that is very effective, but quinine is also present in tonic water. So for those of you who like to drink tonic water, you drink a little bit of quinine with your gin and tonic. So the half-life is 10 to 12 hours and has 80% viability, so it's not as good as acetazolamide. And the therapeutic dose is about 650 milligrams a day. In this case, we are testing a dose of 80 milligrams a day, so it's extremely low, and it's equivalent of drinking about 1.1 liters of tonic water. So that means taking more than 4 gin and tonics in one day. So it is not expected that it's going to be present in many people, but still, this is not our best candidate because of the low viability and also the potential of confounding in people who may drink large doses of tonic water. So the one that we are more advancing is acetazolamide. This is the data showing the bioavailability and the rate of elimination of acetazolamide. It is like the ideal biomarker because it has a very good absorption, it has an excellent distribution, and the metabolism is very, very predictable. Now, one thing that is very interesting of this compound is that it has an elimination from plasma, but then there is an elimination from red blood cells that come after the elimination from plasma. So we can use acetazolamide to predict when was the last time that the patient took the medication. So this is a very interesting candidate. Right now, we are already using acetazolamide in some of our clinical trials. NIDA is now conducting a clinical trial with lorcaserin for the treatment of cocaine dependence. Lorcaserin is Belvic, is a medication for anti-obesity, but we are testing it for cocaine dependence, and we are seeing excellent response to acetazolamide as a biomarker of medication adherence. So we are looking at in real world with this clinical trial, but we expect that in the future we will be expanding the use of acetazolamide as a biomarker. So now, right now, it's not approved by the FDA. It's under research. This data has not been published, but we expect that this is something that we will continue, and especially that we probably will try to translate into clinical practice, and so it can be used by clinicians, especially in those cases or patients that are difficult that have a hard time staying in treatment and hard time following the medication, or tend to lie, or those that are involved in the criminal justice system that we need to know if they are really taking the medication or not. So it's a potential candidate that has a lot of future. Now, in terms of other pharmacological aspects, medication levels is widely used, and I'm not going to talk about medication levels at this point because that's another area that can spend the whole morning talking about medication levels. I'm going to focus more on new medications and new formulations of medications. So new formulations. So we are trying to solve the problem of the multiple dosing of medications to try to compress in at least one dose and having more doses at one time. This is a cartoon showing that combining a medication in one convenient dose. Well, that's not exactly what we are doing, but it's kind of, because some of the long-acting formulations that are being supported or are being by NIDA or are being developed are kind of like this idea of putting a lot of medication with a slow release that the patients don't need to take it every day. So some of the long-acting formulations, the idea is that it has reproducible, sustained delivery of a drug at a target site for more than 1 week by controlled drug delivery systems. Some of the drug delivery systems are oil-based injectable solutions or injectable drug suspensions, supersaturated drug solutions, or polymer-based microspheres, or in situ forming implants. So implants are widely tested right now. So in medicine, we have many examples of long-acting formulations. This is a list of all the approved long-acting formulations for many disorders, but in particularly in psychiatry, for example, in schizophrenia, bipolar disorders. So this is something that, again, NIDA is very interested in moving forward and supporting this type of research. What are the advantages of long-acting formulations? Well, better treatment adherence, of course. Better treatment adherence implies better treatment outcomes. We expect that will reduce the morbidity and mortality, improve the systemic availability by avoidance of the first pass, so you don't have to worry too much about the metabolism. It's a predictable drug release. You don't have the peak and troughs associated with oral administrations. You reduce the dose frequency, so it can be once a week or once a month. And you reduce the risks of inappropriate prescribing, because you only need to prescribe it once a week or once a month. Unintentional overdose, which as we heard in the previous session, is a huge problem. The issue of diversion, as we know with some like methadone or buprenorphine or misuse, and the adverse events associated with the peak and trough levels. And the withdrawal, as we know, is a very big problem, especially methadone and buprenorphine, and also with naltrexone, because when oral naltrexone is administered, you can have very quick withdrawal. And the tolerance that are require higher doses. So there has multiple advantages, but it has, like everything in life, it has also some disadvantages. Some of the disadvantages is that in case of someone presenting adverse events, if it's administered a long-acting formulation, the adverse events are more difficult to control. So this is a serious disadvantage. It has, of course, less contact with the treatment program, because if the medication is administered once a week or once a month or every 6 months, as you are going to hear, some of the medications that are being developed now for every 6 months, so it's kind of like the patient is expected that will not need to come to the treatment as often, and we know, and we are going to hear in the next presentation, the importance of the behavioral and the psychosocial support in this type of treatment. The application risks of local inflammation or infection and the site pain and the allergy to slow-release chemicals, especially with polymers, the risk of medication-medication interaction or drug-drug interactions, and the unintended effects like blocking the analgesic effect, specifically with the long-acting formulation of naltrexone. And one big problem is the unintentional overdose, especially with naltrexone, because of the long-acting blockade of the opioid receptors. With naltrexone, the person can become tolerant, and if that person uses the same amount of opioids that was using before, that amount, because they lost the tolerance, they cannot, that amount of opioids may be enough to produce an overdose. And one of the issues is also that with the FDA requires a big risk evaluation and mitigation strategy program for the long-acting formulations. That was our experience with the development of the implantable formulation of buprenorphine or probufin. So what are the long-acting medications that are being developed right now? That we have 3, as far as I know, for the opioid agonist or partial agonists. We have buprenorphine. So there are 3 formulations of buprenorphine. 2 of them are right now not approved by the FDA. Indivior has a once-a-month formulation of buprenorphine. It has positive results of a phase 3 pivotal trial and is going to the FDA with those results. And the other is a SCAM 2038, is a subcutaneous administration. They have 2 formulations, a weekly and a monthly formulation of buprenorphine, and they also have positive results, and they are also in the process of going to the FDA. The other one that is already approved by the FDA is the implant of buprenorphine or probufin that right now, that was developed by Titan in the United States, it was licensed to Bredburn, so the 2 companies are working together in the United States. So this is in the left side, this is the implantable formulation of buprenorphine. It's a rod that is like the size of a small match. So the rod is implanted under the skin in the forearm. Usually 4 or 5 rods are implanted, and they produce a buprenorphine levels of about 8 milligrams a day of buprenorphine. So it is not a very high dose of buprenorphine. It's a relatively low dose, but that's what the FDA approved. And it is implanted every 6 months, and it has to be removed after 6 months, which is a big issue with some patients coming back to get their implant removed and then put in a new implant, which requires a small surgical incision. So this is the implant, and was approved by the FDA last year. This is data showing the blood levels of buprenorphine and the sublingual buprenorphine, which are very, very similar. And the buprenorphine implants, they are designed to release sustained doses of buprenorphine equivalent to 8 milligrams a day. Now, this is the data that was recently, or relatively recently, published by Rick Rosenthal, showing comparing sublingual buprenorphine and the buprenorphine implant, and this is the retention and treatment. And you can see the retention and treatment with the buprenorphine implant was better than with sublingual buprenorphine. Now, one that I want to disclose, NIDA has not funded this study. NIDA has been meeting with this company. As I mentioned, Camurus is a company from Sweden, and Bredburn is a company in the United States. They are working together in the development of this compound. We have only provided some technical assistance, but we have not been involved in this research. This is the plasma levels of the CAM-H compound. You can see pretty good plasma levels, and you can see here the treatment adherence, the duration and treatment is in general pretty good, and those are the plasma concentrations of buprenorphine with the injection. So as I mentioned, the data is very encouraging. This is those are the results of their phase 3 double-blind randomized study in a sample of 428 adults. Demonstrated non-inferiority and positive treatment differences comparing buprenorphine and the implant and placebo. So this is the other compound that is being developed by Indivior. It's the RVP6000. It's a monthly injection of buprenorphine. You can see the plasma levels are excellent, and the bioavailability in the mu opioid receptor is very good. They also have results of their clinical trial, and both companies, which is fascinating to see two companies that are competing to be the first in the market to have long-acting formulations for the treatment of opioid use disorders of buprenorphine. So this is the announcement that by Camurus and Bredburn, the companies that are working together in the United States for the compound, for the weekly and monthly formulation of CAM 2038, and this is the announcement by Indivior of the acceptance by the FDA of their review. They are not approved yet. They are being reviewed by the FDA, so we expect that we soon will hear if they will be approved or not, and hopefully by next year, if they are approved, they will be available. So we are working with both companies in advancing the research, and NIDA is very supportive in part because those two compounds will greatly contribute to this fight to the opioid crisis that we have right now in the United States, because we can see that the two compounds are significantly going to improve the treatment outcomes, and is going to be a significant contribution to the medications that physicians can use for the treatment of opioid use disorders. Now, there are other medications that are being developed. We have a big portfolio of vaccines. Vaccines are being tested for the treatment of many substance use disorders, including nicotine, cocaine, methamphetamine, and opioid use disorders. Right now is a program looking at vaccines against heroin, against oxycodone, and against fentanyl. The vaccines are administered once a month. Again, the data is, the NIDA is supporting this research, but it's at the preclinical level. And it's also supporting research with monoclonal antibodies specifically against fentanyl. and against some of the derivatives of fentanyl. So this is just, again, preclinical level. It will take a long time before we have anti-opioid vaccines, but at least that's something that we are investing a lot of funds and support in the development. Now, another area that we work very hard with is the development of butyrylcholinesterase. That was specifically for cocaine dependence, but this esterase was abandoned because the results of a phase 3 trial was negative and was for cocaine dependence. There's also a long-acting formulation of methadone that is being developed, or was being developed. It was a monthly injection, and it was a preclinical study, but the implant was too big for clinical use, and it was abandoned. And naltrexone, there are at least 2 formulations of long-acting formulations of naltrexone. Well, there are 3 with the Vivitrol, of course. So, but in development, we have, we don't have, this implant is being developed in Russia and is called Prodetoxone. It's an implant that delivers naltrexone for 2 or 3 months. It's approved in Russia. Now we are beginning to work with a company in NIDA. We're trying to develop this formulation of Prodetoxone in the United States. There's another implant that is being developed in Australia. Apparently works for 6 months, and NIDA right now is very interested in working with this company. So we are hoping that at least those 2 companies and any other companies interested in developing long-acting formulations of opioid antagonists will come on board and will work with us in developing those formulations. So I'm not going to spend time in the other slides. I just want to say that Opioid entered a collaboration with Titan Pharmaceuticals. Titan Pharmaceuticals is the company that developed Probufin, the long-acting formulation of Probufin, and they have a technology called Proneura, and they enter a collaboration with Opioid. Opioid is the company that developed in the United States and naloxone spray, Narcan spray. And so they are collaborating to develop long-acting formulations of opioid antagonists using the Proneura technology. The chair is calling me and saying that I'm running out of time. I was just very quickly mentioning some of the devices that NIDA is supporting or is beginning to support to assess treatment adherence. Those are some devices include microchips that will be included in the capsule that generate a signal, and via Wi-Fi that signal can be read in an iPhone, any smartphone or any type of device that can read signals. This is one that we are using right now. It's called the iCure. It's a facial recognition device that uses the phone, and when a person takes the pill and assess the treatment adherence with facial recognition and demonstration that the pill is being taken. This is technology that we are also using in the lorcaserin study that we are conducting right now. This is another technology using a tagant, which is a uniquely coded material or a fingerprint material that when you ingest, is metabolized, then it can be exhaled, and it can be evaluated in like a breathalyzer. There's also another technology using microchips in capsules. And in summary, well, I think I convinced you that treatment adherence is a significant concern in substance use disorder treatment, specifically in our case with the opioid crisis and opioid use disorders treatment. Efforts to improve treatment adherence include behavioral interventions, psychosocial interventions, contingency management, and also pharmacological interventions like biomarkers, for example, acetazolamide, new long-acting formulations like we have now with buprenorphine, and we hope to have in the future with long-acting formulations of naltrexone, and hopefully other new medications that we have long-acting effects. and the devices that are being developed right now. Thank you so much for your attention.
Merci Ivan Montoya pour cette présentation. Donc on a vu par rapport à la question de l'adhérence, la compliance et donc de l'efficacité les aspects technologiques. Et maintenant Roger Weiss va intervenir pour faire le point sur les aspects relationnels et pour augmenter l'adhérence et la compliance. Roger Weiss est psychiatre et addictologue. Il est à la fois clinicien et chercheur. Il travaille à l'université de Boston et il est responsable de la filière de soins des addictions à l'hôpital McLean à Boston. Roger.
Thank you so much. Thank you to Jean-Pierre and Marc for inviting me to this wonderful conference. Thank you all for your attention, and I will start. So today I'm going to be talking about studies of behavioral interventions in addition to buprenorphine to treat opioid use disorders, pose some key questions to help us understand the results of these studies, suggest research strategies to further understand the issue, and then suggest clinical approaches for this population. So the Drug Abuse Treatment Act of 2000 in the United States that established buprenorphine prescription said, quote, physicians must attest that they have the capacity to refer addiction treatment patients for appropriate counseling. So what is appropriate counseling? 4 major studies have shown that adding counseling to buprenorphine and medical management is not superior to buprenorphine plus medical management alone. I'm going to review all of these and say, what is the role of behavioral interventions in office-based buprenorphine treatment? So here are the 4 major studies. I'm not going to go through them in great detail. The first one back in 2006 by Filene et al. Compared standard medical management, which is 20-minute visits, versus enhanced medical management, which is 45-minute visits, delivered by the same people, and they found no added benefit of the enhanced medical management. There was a tremendous drop in the number of days of opioid use in both groups, but no difference between groups, and importantly, only 45% completed the 24-week trial. Filene et al. Did another study in which they increased the level of counseling, and they did cognitive behavioral therapy in addition to standard medical management, weekly for 12 weeks. No added effect of cognitive behavioral therapy with the same improvement in both groups. Walter Ling and collaborators studied cognitive behavioral therapy, contingency management, and medical management. People got standard medical management plus CBT, plus contingency management, plus both, or neither one, and there was no added effect of behavioral treatment. Again, people improved, but the same in all the different groups. And again, only about 50% completed the trial. In a study that I led as part of the National Institute on Drug Abuse Clinical Trials Network, the Prescription Opioid Addiction Treatment Study, we had 653 patients who were either exclusively dependent on prescription opioids or almost exclusively, and people received either standard medical management or standard medical management plus individual drug counseling. And they got different lengths of buprenorphine treatment. Everybody started with a 4-week taper, and people who relapsed during the taper got 12 weeks of buprenorphine stabilization. We found that in the taper group, only 7% of people had successful outcomes, meaning that they were abstinent from opioids or nearly abstinent. In compared to those who relapsed during that taper and then were put on stabilization, and the number of people successful went up to 49%. So it was a tremendous advantage of buprenorphine treatment. However, there was no added benefit of counseling. So that's 4 studies showing no added benefit of counseling. So what are the questions that come from all of this? One, is buprenorphine that good that you don't need counseling? Is medical management that good? Because in all of these studies, people receive medical management. Is counseling that ineffective for this population? Could the research designs in these studies have affected the outcomes? Are there subgroups of patients who respond to individual counseling? And what outcomes should we be looking for? So, first question, is buprenorphine that good? Well, it's really good, but there's definitely room for improvement. For example, in studies that have compared buprenorphine with methadone, typically you show better retention for methadone. One multi-site study showed 74% versus 46% retention for methadone, and methadone retention is higher even when the treatment is self-selected, 70 versus 43%. Even though retention is better in methadone, people in buprenorphine treatment typically or often have fewer opioid-positive urines. So the next question, is medical management that effective? First of all, what exactly is medical management? The active ingredients of medical management in all the studies that I've talked about is there's an overall health check, urine monitoring, checking on both the medication efficacy, adherence, and tolerability, monitor craving, advising people to abstain, advising them to attend mutual help groups such as Narcotics Anonymous. But in all of these studies, the medical management that was delivered was more intensive than the community standard. In some of them, it was once a week. In others, once a week and then once every 2 weeks, whereas a typical medical management might have monthly visits and not necessarily with at the length of 20-minute visits that were shown in these studies. So another question, are behavioral treatments that ineffective in this population? No. There are 3 studies that have shown benefit of behavioral treatment. One of them, by Warren Bickel and his group, compared people, they got either standard methadone-style counseling, clinician-delivered community reinforcement plus contingency management, vouchers for negative urines, and computer-delivered community reinforcement and vouchers for negative urines. And the outcome showed that the community reinforcement and contingency management had longer periods of abstinence from opioids and cocaine. Christensen, more recently, studied buprenorphine plus contingency management, in which people were paid for negative urines, and buprenorphine plus contingency management plus a computerized therapeutic education system with web-based interactive topics that people dealt with 3 times a week. The outcome showed better retention in those who got the contingency management plus the TES, and longer continuous abstinence in those who got contingency management plus the therapeutic education system. Richard Schottenfeld did a study with a 2x2 factorial design in which people got either buprenorphine or methadone, plus either contingency management or performance feedback, in which they were told what the results of their urine tests were, but they weren't rewarded for negative urine screens. And the outcome showed the benefit of contingency management as long as the vouchers were escalating, which is when these studies typically show contingency management to work. So we've seen that the counseling studies didn't show an effect, but anything that had contingency management in it actually did show an effect. So how might research designs have affected the outcomes in these trials? If you look at the 4 studies that found no additional benefit of behavioral interventions, the first 4 that I mentioned, all had many solid features. They were rigorous, randomized controlled trials with large sample sizes, manualized interventions, and regular urine toxicology tests. The studies, But these studies all had more intensive medical management than we typically see in the community, and they also had higher buprenorphine doses than the studies that did show a benefit. All the studies that did show a benefit had lower buprenorphine doses, and they all used contingency management and/or computer-based treatment. Another question. Are there subgroups of people that benefit from behavioral treatments? Just because a study shows that for a group as a whole they don't benefit doesn't mean that there are certain subgroups of patients that don't benefit. So in the prescription opioid addiction treatment study that I led, we were interested in that particular question, and so we hypothesized that there might be a couple of characteristics of patients that did respond to counseling. One, people with more severe problems, because in general, people with more severe problems benefit from more treatment. And as an example, we thought of patients who had used heroin because they had a worse outcome in our study and in most studies. Those who had greater attendance at treatment sessions, i.e. more adherence, as per what Dr. Montoya was talking about, or the interaction of the two, and also people with comorbidity of either chronic pain or psychiatric illness. So, looking at patients with psychiatric illness, 50% of the patients in that trial had another psychiatric disorder. And those who had a psychiatric disorder had more successful outcomes if they received drug counseling. 61% were successful with counseling, and only 43% of those with psychiatric illness were successful with medical management alone. Subjects without psychiatric illness had the same outcomes whether they had counseling or not, and that interaction was significant. We also looked at severity, so we looked at patients who had used heroin, and we only looked at people with treatment adherence, people who actually went to their sessions. And we had a fairly interesting finding. If you look at the right side of the slide, this is a bar graph that shows the success rates of people who receive drug counseling or no. Drug counseling is in blue, no drug counseling is in red. And if you look at the right side, these are people who had never used heroin. And what you see is there was no difference between people who got drug counseling and didn't get drug counseling. The left side of the slide shows people who had used heroin, and these are people who had only dabbled in heroin because those were the only people allowed into this prescription opiate study. But you see there that people who had used heroin, if they got counseling, they were more than twice as likely to have successful outcomes than people who only received medical management. And these are people who were good attenders at whatever they were assigned to. Other studies that have looked at subgroups, Moore did a secondary analysis of the Filene cognitive behavioral therapy study and found that people who were dependent on prescription opioids had better outcomes when cognitive behavioral therapy was added. Primary heroin users did not benefit from adding CBT. So what outcomes should we aim for when we do these studies and when we do our treatment? So the literature typically focuses on two major factors: one, treatment retention, and negative urine drug screens. And there tends to be less emphasis on other important areas such as functioning and overall well-being. And it may be that behavioral treatments help these things, even if they don't necessarily help with retention or urine drug screens. And so the outcomes that we should be looking for are stable home, employment, no criminal activity, overall medical and psychiatric health, and overall good functioning. So, looking back, what have we learned? We've learned buprenorphine is an excellent treatment, but there's a lot of room for improvement. Medical management is a robust intervention, but exceeds the community standard in these studies. Contingency management is likely useful in this population. Research designs, such as the intensity of medical management and the buprenorphine dose, can influence outcomes. Some subgroups respond better to counseling than others, such as prescription users and those with co-occurring psychiatric disorders, and that we should focus on functional outcomes. So how to proceed? Well, one way is to consider a stepped care model. And in thinking about that, we know that many patients do well with buprenorphine and medical management alone, but we're not good at predicting who will do well with that and who won't do well. There are limited resources, both for medical management and for behavioral treatment. Another important factor is that some patients don't want counseling. In the prescription opiate study that we did, we had to post our counselors outside the physician's door who gave them the buprenorphine so that the patients didn't run away before they got their counseling session. And understanding the importance of an early treatment response may help our decision-making in deciding who should have counseling and at what level. So how do we understand that? And as part of our prescription opiate study, we asked the following question: does early response to buprenorphine predict treatment outcome in prescription opioid dependence? So we know that some medications, such as antidepressants, may take a number of weeks to work optimally, and therefore waiting several weeks to examine treatment response may be helpful. We don't know the typical time course of treatment response to buprenorphine in the treatment of prescription opioid dependence, however, and knowing this could help guide clinical practice early in the treatment of this population. So we asked the following questions. Is it possible to tell early in treatment whether a prescription opioid dependent patient is likely to have a successful buprenorphine treatment outcome? And how early can we tell this accurately? So the way that we examined this is by looking at two different factors. One's called positive predictive value and the other is negative predictive value. Positive predictive value is the degree to which a good start predicts a good final outcome. So in this case, the degree to which initial opioid abstinence in the first week, first couple of weeks, first 3 weeks, etc., predicted the final successful outcome, which was at week 12, weeks 9 through 12. A negative predictive value is the opposite. Does a bad start predict a bad outcome? So does use of opioids in the first week, first couple of weeks, predict that people will not be abstinent at the end of treatment? So what about the positive predictive value? So this is what we found. Is this one of these a laser pointer? Oh, back here? Whoops, what did I do? Oops. Which one? This one. That one. Okay. Good, thanks. So what we show here with the positive predictive value is if you abstain in week 1, what's the likelihood that you will be abstinent in weeks 9 through 12, which was our measure of success? And it was 49%. So basically, it's a coin flip, maybe even a little bit worse than a coin flip. So abstaining in week 1 doesn't tell you anything about how you're going to be doing at week 12. If you abstain in weeks 1 and 2, it gets a little better, 56% predictive value, and it doesn't get much better if you look at the first 3 weeks and the first 4 weeks. So not a great prediction. On the other hand, if you look at negative predictive value, if you use opioids in week 1, the likelihood that you will be using opioids at the end of treatment is 80%. And if you use in weeks 1 and 2, the likelihood is 94%. So there are very few come-from-behind victories in this. If you get off to a good start, that's fine, but there is room for trouble. If you get off to a bad start, the likelihood that you will be successful 10 weeks later is very, very low. So the first 2 weeks of treatment with buprenorphine yield very important information. People who abstain from opioids in the first 2 weeks have a pretty good chance of good 12-week outcome, but not great. However, those who use opioids in each of the first 2 weeks, and even in week 1 alone, have very little chance of abstaining by week 12. Now, in our study, we could not increase the intensity of psychosocial treatment because we were studying the role of psychosocial treatment. However, in clinical practice, you can increase the intensity of psychosocial treatment, and that should be considered if patients don't do well initially, and that's what I mean by a stepped care model, where you can start in terms of the intensity of psychosocial treatment can be whatever you and the patient agree on. If the patient doesn't want counseling, they don't need to start with counseling. If they want counseling, they can start with whatever intensity, but if it doesn't work quickly, then they probably need more. Now, we don't know that having more will actually improve outcomes because we didn't study that, but it seems reasonable that that would be something to try. In our study, we were able to increase the buprenorphine dose, so that was not the issue. So what can we conclude? Is buprenorphine that effective? Yes, but there's room for improvement. We need to improve retention in office-based treatment. Is medical management that effective? Yes, but intensive medical management may not be feasible in community-based settings. Are behavioral treatments that ineffective? Well, there's evidence for contingency management and perhaps computer-based treatment. Behavioral treatments may play a larger role when medical management is less intensive. The effective research design, there have been no studies of buprenorphine plus counseling without high-quality medical management. So, yes. Do subgroups benefit? Well, data is needed on which patients benefit from medical management alone versus those who need more intensive behavioral interventions. What outcomes should be considered? Improvements in overall functioning, approaches that appeal to patients and that increase retention, and consider stepped care models. I'd like to acknowledge the National Institute on Drug Abuse grants, my co-author, Kathleen Carroll, an article that reviews this in more detail was published in the August, just a couple of months ago in the American Journal of Psychiatry. And thank you. I guess there's no time for questions right now, but thank you.
Merci à Roger Weiss pour cette présentation passionnante. Et sans plus attendre, on va passer à Adrian DUNLOP d'Australie, qui va donc se focaliser sur un aspect particulier qui est la question de la parentalité et addiction.
Bonjour.
Et j'ai oublié de mentionner, Adrien vient de l'autre côté de la planète, d'Australie.
Okay. Bonjour. C'est un grand plaisir d'être ici à Biarritz lors de cette excellente conférence. Merci à Jean-Pierre, à Marc, à ATHS, à Augustine, Cécile de m'avoir permis de parler. Je vais contribuer en anglais. Mon français est trop limité. Merci. So I'm going to talk to you this morning about a small study with some interesting findings that we did in New South Wales, Australia, to try to improve the capacity of parents who have young children and the parents have substance use disorders. To advance the slides. This one? Yeah, this one. Right, thanks. And I have no conflicts of interest to declare, and this work was funded by the New South Wales Ministry of Health through our competitive research funding round. I'd like to start by acknowledging the other investigators who worked on the study and the clinicians and, of course, the patients who participated in the study, especially Professor Louise Newman. So the background, the context to the study, in the major teaching hospitals in New South Wales, in Sydney and in regional New South Wales, there are services for pregnant women who have a current drug use problem to try to enable better treatment of their drug use during pregnancy, but also to assist them to better engage with antenatal care for their pregnancy. and to try to provide some assistance for their partners as well. And the key goal of these services is primarily to engage this group of women in treatment, and then to make sure that they're getting adequate treatment, that the obstetric team, the midwives, have an understanding of the substance use problem, and that doesn't limit their ability to interact positively with the women. So in New South Wales, in the region I'm from in Australia, there's about 95,000 births each year, and these services see somewhere between about 600 and 1,000 births each year. The principal substances are opiates, either prescription opiates or heroin, amphetamines, cannabis or alcohol, but we think that we're only detecting or we're only having clinical contact with a very small proportion, especially with alcohol, and we're aware that there's a much larger group who have problematic alcohol use that continues through pregnancy. And it's possible to most easily detect women who are on a methadone or a buprenorphine program because we already know that they're on a program. With other drugs, of course, it's much harder. The particular problem that exists is that this group has a very high level of contact with agencies of child protection, and there's a very high rate of assumption of care at birth. So something like typically 20% to 30% of women who go through these services lose custody of their children at birth, and then in the following year or a couple of years even more will do so. So this is a conundrum for providing services. If a woman makes contact with the service, we hope to improve their health and the health of the baby and the health of the family, but the women know that if they declare their drug use, then there's a risk that they will lose custody of their baby at birth. The system indeed in Australia is so overwhelmed in terms of child protection risk that it can't adequately respond to the number of concerns that are raised. So the primary problem, of course, isn't just the consumption of drugs themselves, although clearly intoxication for parents or for pregnant women is not such a good thing. But it's the combination typically of these factors with other risk factors that this group experiences. So for example, partner violence, homelessness, poor mental health, poverty, and these factors contribute together to increase risks for the child and decrease the capacity for adequate parenting. So there are, of course, a number of programs that have been developed to try to help parents improve their ability to parent, but typically these have not been developed specifically for people with substance use problems, and they may not take into consideration the fact that there's low education and low levels of literacy in this group. And to briefly review the cycle of attachment, if a baby has a need and it's met, then over a period of time the baby develops trust and develops secure attachment. However, if the needs aren't adequately met, there's a risk, of course, that the baby develops insecure or disorganized attachment. And of course, clearly, to develop neurologically well and to develop a child's security, having a long period of time of stable interactions with at least one key parent figure is very important. So the objectives of the study that we conducted were to pilot and assess the provision of a comprehensive attachment-based group parenting program called Parenting with Feeling, focusing upon improving parental self-representation, emotional understanding and attachment relationship with children. And the key difference with some other programs is that it's group-based, it's not individual-based, that it's specifically developed for people with substance use disorders, accepting that there's going to be a high rate of mental health problems and experience of trauma. And we were looking to deliver this to parents who had children between age 2 months and 24 months and were currently at a risk of significant harm. So that means that the child protection authorities were aware of them and could intervene. The program went for 10 weeks, so each week there was a group for 2 to 3 hours each week. Some food was given during the week to encourage the parents to attend. Typically it was a psychologist and a nurse who were providing the intervention. It was an experiential intervention, so the parents brought their babies along and would demonstrate particular behaviours. They'd also do some coaching, so they'd watch a video and look at different ways of responding to different problems. A key part was understanding the baby's development and what the expected development goals were, so the parents could understand if the baby or the child wasn't meeting their development goals. And so through these techniques, we thought it was possible to look at parental attachment, emotional availability, and parental reflexive capacity. So you can see there's a list of the headings. Each week wasn't absolutely strict, so some of the discussion might go from week to week, but it gives you a sense of the key topics that were delivered in these group interventions. So the key outcomes that we wanted to measure were involvement with the Child Protection Agency, experience of trauma, drug use, mental health, and this parental reflective functioning or parental functioning. And this was done at baseline at the end of the 10 weeks and then further at 6 months. And I'm going to particularly talk to you about the child protection outcomes this morning and the parental functioning, baseline and end of treatment, but also provide you some information about at the end of the 6 months. So we were able to recruit 33 parents, 30 actually commenced the treatment, 22 finished, and at 6 months we could contact 14 for follow-up. We could get information, however, on the whole 33 because we could obtain data from the Child Protection Agency, so on that indicator we could get a much higher follow-up. So you can see of the 22, 16 were mothers and 6 were fathers. The average age was 30 years with a range between 19 and 48, sorry. The average age of the baby was 5.5 months, the range between 2 and 22 months. Just under a quarter were Indigenous Australians, Aboriginal Australians, 95% were unemployed. 2/3 had limited education, so they hadn't finished secondary school, but 1/3 had some ongoing education beyond school. And about 2/3 were in a relationship, either de facto or married, and the remainder single. In terms of the drug treatment they were receiving, 17 of the 22 were on methadone or buprenorphine maintenance programs, and 5 were receiving drug counselling. The drugs are slightly different from the treatment because you'll see some people will be on methadone or buprenorphine treatment, but their heroin or opiate use might be stable, but they may have another drug use problem. So amphetamines, we spread between amphetamines, cannabis, heroin, and benzodiazepines, and some other drugs. In terms of family conflict, this was not uncommon. Child risk was quite high. And recent death of a significant other was also notable in this group. Most pregnancies were not planned, and nearly 2/3 it was the first pregnancy. So just quickly to take you through the scores, it's probably not a surprise to this audience, but the experience of trauma by this group was very high, so it was very common to have experienced themselves physical abuse, physical neglect, sexual abuse, emotional abuse, or neglect. So in terms of the outcomes in terms of parental reflective capacity, parental functioning, really the key message is we didn't see a big change. It's of course a very small sample, and we had a dropout, so it's maybe not surprising. We did see a small increase in knowledge, understanding about infants. We did see some clinician-rated improvement or assessment of improvement in functioning. That's probably clinically significant, a jump of 10 on that scale. a slight deterioration in parental stress, and this may be that after going through this program, parents have a greater understanding of what they can do and what they can't do, and that might give more stress rather than less stress. But on the other factors, the parent developmental index and the emotional availability, there was no change. But I will take you through some qualitative data through this as well, because it's a little interesting. But the unexpected result, we saw that there was a very significant decrease of risk of significant harm and involvement by the Child Protection Agency while parents were engaged in this program. So it was a 4.5-fold reduction in risk of significant harm and nearly 7 times decreased risk of having a child removed. Of course, this is a very small sample size, and I shouldn't make too much of this impact, but we weren't expecting to see such a large impact on a very small numbers in terms of involvement of the Child Protection Agency and loss of custody. So I'll now just quickly describe some of the qualitative information in one of the instruments, the parent developmental interview. And there's some 2 examples I'll give you. So you can see before the group, this parent, it was a mother, said she's very upset, she does not know what's wrong, she doesn't know how to find out what's wrong. And then afterwards she's saying, I feel like I've learned through this not to feel guilty about it. The baby will cry, the baby will be tired at times. She needs to learn to soothe herself sometimes. Another example, there's a question, do you think there are experiences in your child's life that you think have been a setback? And you can see before the parent, again, it's a mother, is saying, no, I don't think so. And then afterwards, you can see there's a deeper level of reflection. My past, the mother herself had child protection involvement. She didn't have a sister because of that, because she'd lost custody. She didn't have other siblings. Yes, my past impacts upon my current life. So I guess what are some of the key considerations? The first thing is we were able to recruit the group that we were looking to recruit. In fact, it seemed to become popular over time in these antenatal services for women to be interested, probably because they perceived that this was something that was an assistance for them, not something that was a risk for them. We didn't see a difference in this sample in parental reflective functioning or parental capacity, but we did see this difference in a reduced risk of harm. Again, it's a small study, and of course we'd have to replicate that. Where to from here? Fortunately, the local government has decided to increase these services for drug use in pregnancy and expand the services not to concentrate only on the prenatal period, but also to make sure that they have ongoing engagement with women for up to 2 years after birth. So we plan to replicate this program in multiple centres and have a comparison group and to see if our findings can be replicated. Merci beaucoup.
Je remercie les orateurs. Vous avez noté l'intérêt majeur de ces exposés. Donc nous n'aurons pas le temps de poser des questions. Je voudrais juste faire une remarque à propos du dernier exposé. Nous allons donc, comme vous le savez, dès midi passer à une autre session. À propos de ce dernier exposé, où nous avons apprécié les qualités de clinicien d'Adrian DUNLOP, je voudrais signaler que nous avons mis en place à Paris, en 1988, une unité mère-enfant pour mères désocialisées, toxicomanes, séropositives. Et donc, dans l'exposé d'Adrian, vous avez noté qu'ils étaient en face de mères souvent sans domicile fixe, souvent très, très lourdement toxicomanes et qui n'avaient pas été correctement suivies pendant leur grossesse et souvent qui arrivaient à la maternité pour accoucher et qui étaient soit mises à la porte au bout de 2 jours, 3 jours, avec leur bébé dans la rue, soit qu'on leur retirait le bébé. Eh bien, l'unité mère-enfant à Paris, avec donc Didier Touzeau et Anne Coppel, était destinée justement à accueillir des mères qui venaient d'accoucher, et donc pas à partir de 2 ans, puisque vous avez insisté sur l'importance de l'attachement sécure et insécure. C'est très très tôt que ça se met en place. Et donc, l'intérêt, bon, je veux dire relatif, hein, je ne veux pas dire que c'est une panacée, mais enfin, l'intérêt de cette unité mère-enfant, c'était donc d'accueillir des mères avec leur bébé qui avait 2 jours, et donc d'être avec elles dans cette unité résidentielle. Donc elles dormaient là, on était avec elles pendant des mois, et on leur confirmait qu'elles étaient une bonne mère. Et ça me semble intéressant en termes de prévention. Voilà, c'est juste ce que je voulais dire comme alternative à ces programmes de consultation externe. Peut-être que penser, parce que l'Australie est un pays très riche, peut-être penser à des unités mère-enfant résidentielles. Je vous remercie de votre attention. À tout à l'heure.
Alors, on vient de me signaler qu'on pouvait prendre un peu de... Comme on est juste à l'heure, on a le droit à un petit temps de retard. Voilà. Et donc, s'il y a des questions sur les... Voilà. Donc, si vous avez des questions... Oui, et je vois une question.
Bonjour, je suis docteur Merlin, je suis dans le Nice-sous-Bois, la région parisienne. J'ai une petite question concernant l'implanant. C'est un implanant de 6 mois. On utilise, nous, chez les femmes pour un contraceptif tous les 3 ans. Donc, vous allez le mettre et l'enlever tous les 6 mois. Est-ce que ce n'est pas lourd? Et deuxième question, pour les biomarqueurs, concernant les maladies chroniques, le diabète, l'hypertension, est-ce que vous avez des informations concernant l'utilisation de ces biomarqueurs chez les maladies chroniques, chez les malades qui présentent une maladie chronique? Merci.
Question pour Ivan.
No, I don't have any information. They are only being tested right now for substance use disorders. They are not being tested, as far as I know, for other clinical conditions. But eventually, it will be. If we succeed in developing those biomarkers for substance use disorders, they can be translated to other medical conditions.
Merci Ivan. Une autre question ici, oui.
Oui, this is for Ivan on Montoya. How do you deal with long-acting treatments about the day-to-day variations in need for opioids or anything else? So, which can be a disadvantage if you have a long-acting treatment, how you deal with day-to-day dose adaptation?
Yeah. Yeah, that's a very important question, and so far our experience with long-acting, with the implantable buprenorphine, because of the low blood levels of buprenorphine that I mentioned, only the equivalent of 8 milligrams a day, what is being done is adding oral buprenorphine to the implant. But the idea with the injectable formulations that are hopefully being approved, they will deliver higher buprenorphine levels, and there probably will not be much of a need to add oral buprenorphine.
Joignez-vous à moi pour remercier Aimé, Charles, Nicolas, Ivan Montoya, Roger Weiss et Adrien Dunlop.